Hi, today we are going to talk about suicide and suicidal risk and assessment. First, let's start off by defining what suicide is, and there's various definitions. Some look at suicide as self-injurious behavior, right, with the intent to die. The CDC, the Center for Disease Control and Prevention, define it as death caused by a self-directed injurious behavior with an intent to die as a result of the behavior. Merriam's dictionary defines it as being or performing a deliberate act that results in the voluntary death of the person. Typically, when we're talking about suicide, there is a precipitating event, meaning there's something that happened, there's some trigger, there's some life event that happened, and they have a diminished ability to cope with it, or the coping skills that they typically use are not working. And on top of it, there's a feeling of hopelessness and helplessness. There's a feeling that they are a burden to others. There is guilt and shame that they have with themselves. And so when those factors typically are what you will see with people who are experiencing either suicidal ideations or have had suicide attempts. So typically people who have suicidal ideations or have had attempts, they are trying to seek a solution. Okay, so the purpose of the suicide is to seek a solution to their issue, right? A lot of times, again, they're feeling hopeless, helpless. They feel as though it's the end of the road, that there's nothing that they can do, that there's no way they can get out of whatever bind they're in, or whether that's psychological, emotional, or physical. There is typically the prevalence of a mental health disorder. So one of the things that you will ask in your assessment when you're assessing a client is if they have any mental health diagnoses, if they have been previously hospitalized for a mental health issue. If they have, you want to find out when and where they were hospitalized and for how long. Some stressors that they have, again, which is a common element in people with suicide, is they are frustrated because they have a psychological need that is not being met, or they have an emotional need that is not being met. And the goal of suicide is to lack consciousness, right? It is to get away. It is to be at peace, and to stop whether it's the emotional pain or the psychological pain or the physical pain. And again, that's the stimulus, is that intolerable psychological or physical pain, and that is the driving catalyst for the individual. Now, a lot of times, they will have a feeling of ambivalence and uncertainty. One, they will have ambivalence and uncertainty about their own lives, but they also have ambivalence about going through with the act, which is a good thing. We like it when clients are ambivalent and don't have, aren't resolved and, defined that this is what they are going to do. So whenever they're ambivalent, that's always a good thing, because that gives, you the opportunity to help assist them, and give them the support that they need. Because again, the state that they're in cognitively is they feel constricted. They feel as though they have tunnel vision. They feel that there's just a narrow lens that they have to look through in their lives, and they're not finding any solutions. And again, the action of suicide is so that they can escape, right? Is so they can get away from the problem. One of the interpersonal acts that typically happen, especially for completed suicides, is that communication of intention. And that's why it's very important to listen to people and kind of watch them and see how they are, because they may tell you via text message. In completed suicides, there may be a suicide note that gives further explanation of what they're feeling and why they did it. So you always want to make sure that, if you receive any messages, telephone, even if they're passing thoughts, you definitely want to take heed to those. And then one thing that's consistent with people, when we're talking about suicide, is that they have a history of unhealthy coping skills. It's not something that just occurs. They typically have had a history of not being able to cope, of not having the emotional regulation skills needed to deal with situations. Another thing is that there are some common mental health disorders that are typically associated with suicide. So when you are assessing a client and you ask about their previous if they have any current or previous diagnoses, mental health diagnoses, a lot of times you will hear depression, anxiety, bipolar, schizophrenia, personality disorders as being some of the conditions that clients have, which put them at an increased risk for suicide. Actually, the DSM-5, one of the updates with the DSM-5 was the addition of a section called suicide risk that is located amongst various disorders. And that is to emphasize that individuals who typically suffer from these disorders are at a higher increase for suicide. Medical conditions are also associated with suicide risk as well. Typically, they will be medical conditions that are chronic, pervasive, they're debilitating, they impact one's daily functioning. So diseases like Cushing's disease, Parkinson's, Huntington's disease, hypothyroidism, having a stroke, the severity of the stroke, and how debilitating it is, and any traumatic brain injury. So all of those, HIV, terminal cancer, all of those conditions, those medical conditions can lead to a secondary condition of depression. And that depression, therefore, increases the risk for suicide. The next thing that is important to look at and think about is the interpersonal psychological theory of suicidal behavior. And basically, it's saying that there are three components that lead to a suicide attempt. And those three components are the thought of, I am a burden, the thought of, I do not belong, and them having the ability to self-injure themselves. So being a burden, feeling as though they don't belong, and having access to injure themselves leads to a suicide attempt. Now, when you are conducting a suicide risk assessment, there's a lot of factors and a lot of information that you want to gather so that you can accurately assess whether they are a low, medium, or high risk for being a danger to themselves or a danger to others. So of course you're going to take their demographic information, you're going to take their personal history, so things like their age, race, marital status, employment status, the number of children if they have if they've ever served in the military, right? Again, that history of any previous mental health diagnoses, any previous attempts, any previous hospitalizations. If there have been prior attempts, that does put one at a higher risk for completion. So if there have been multiple attempts, then that further increases the risk. You want to inquire about the methods and the means and what happened leading up to their previous attempts. If there are multiple attempts, like more than 3, then typically what you'll want to do is ask about their very first attempt, because one, that gives us an idea at what age they kind of lost that ability to cope with situations. And you want to ask them about their worst attempt. All right, so the first and the worst are what you want to ask about if the client has a history of multiple attempts, and you want to find out what their reaction to those attempts were. What were the lessons that they learned from those attempts? How they perceived the lethality of their attempt and the probability of rescue. So when we're talking about their reaction to the attempt, what is their comment about it? I work in mobile crisis in my state in Arizona. I'm a mobile crisis specialist. And so I've had people say, I slit my wrist, I was in the bathtub, I slit my wrist and my neck. I had to go to the hospital. I was in the hospital for 7 days. I had to have 6 blood transfusions. And yeah, suicide's off the table for me now. Right? So their reaction to that attempt was, not going to do that again. And that was, the lesson that they learned, right? Like, yeah, that was painful. I'm not doing that. The lessons learned. Some people, so in that particular instance, that client kind of learned their lesson from their first bad attempt. Others, the lesson may be, instead of me taking 10, I'm going to take 50 so I can make sure it gets done this time, right? And so again, those types of statements that you hear when you're trying to do your assessment are important because that kind of lets you know where they are currently at. If they are saying, if they have just thought of a better way to complete the suicide, then we know that there's still a very high risk because that thought is still in their head, and now they've learned their lesson and they know what to do essentially to get the job done. And then the perceived lethality deals with how lethal was the attempt. So for instance, someone said that they, someone who jumped off of one story, a one-story building. Were they really trying to kill themselves, or were they trying to injure themselves to the point that would bring awareness and bring attention to whatever situation they are going through? If someone says like, yeah, I wanted to end my life, I took 2 aspirins. What are they really trying to end their life by taking 2 aspirins as opposed to someone who said, I took 15? Right? And then, of course, you want to assess their current suicidality to see if they currently are having, any thoughts or intentions or ideations of harming themselves. And so there are a lot of risk factors that you will take into consideration, and a lot of those risk factors you are going to hear when you talk to the client. So socio-relational, that's a big one. People breaking up, the breakup of a relationship, a divorce, a separation, the death of a loved one, the death of a significant other, the death of a child. Situational factors, maybe they lost their job, maybe they have a gambling problem, and now, they're so far behind on their home that now they're about to be foreclosed, so now they've got a homelessness issue on their hands. Again, the medical conditions, the mental status, what is their current mental status? What's their affect like? Do they appear depressed? Are they talkative? Are they cooperative? Do they have the proper affect? Meaning, do their emotions match the current situation? If they're talking about a previous attempt, are they laughing and giggling about it? So that's what we mean when we're talking about the proper affect. And of course, your psychological factors, your behavioral factors. So are they engaging in any different behavior, isolating themselves from people, not eating or sleeping? And then some actions that could indicate that they do want to end their life, like they may have started writing out a will, or they may have gotten rid of, items, items that are important to them. And then you also want to look at protective factors. And protective factors are those positive factors that kind of help protect them from those suicidal ideations or attempts. So protective factors are things like family support. They have children. So you might hear people say, I think think about killing myself all the time, but I could never do it because I could never leave my kids, or I could never leave my husband, or I could never do that to my mom. So those are protective factors. If they're active, if they have, if they're active in different groups or organizations in the church, if they have some spirituality, if their culture, I think about it all the time, but it's totally forbidden in our culture to commit suicide, right? So all of those things you're going to take into consideration when you are assessing a client for risk. And again, do they have a plan? How well thought out is the plan? Some people are like, no, I think about it, but I've never thought about how I was going to do it. And some people have a plan. They're like, yeah, I'm either going to shoot myself, or I'm going to OD on some pills, or I've also thought about running out in front of traffic. So if someone has kind of multiple plans, then that would definitely put them at a more elevated suicidal risk. So again, you want to evaluate all of those different factors, the good factors, the protective factors, their vulnerabilities, their medical condition, their previous history, their current functioning, what's currently going on right now, and of course their history. And then after you have compiled all of that information, then you're going to rate them as either low, medium, or high risk for either being a danger to themselves or a danger to others. And then based on that rating will determine your next steps. So typically if someone has been rated a low risk, then typically a safety plan is what will be enacted for them. A safety plan, which you have a copy of as a handout. A safety plan basically is a plan for what the client will do if they start getting those feelings again, right? If they start getting those warning signs. So that's why we have a warning sign section on there. We have safety precautions. So if they said, well, I want to OD on medication, and they have medication in their home, then a safety precaution that we would note on that safety plan is to lock up medications. If they said they want to cut themselves, and if they live with someone, or even if they don't live with someone, then we would contact like a support and have them lock up sharp items. And then of course the main safety precaution is if at any point in time they're ever feeling unsafe, to call 911. If you look next on the safety plan, the next section is the warning signs. So when I need to reach out. So when the client becomes feisty, or notices that they're isolating themselves, or noticing that they're not sleeping, or that they're sleeping excessively, or that they no longer have an appetite, or that they have this overwhelming sadness coming over them. When they get those warning signs, then that's when they're going to reach out. So what are they going to do? Well, the next section is coping skills and strategies. So, what are their coping skills? Do they attend church? Are they already in therapy? If they've already been in therapy and they've already been introduced to some coping skills, utilizing those coping skills. Me, as part of the mobile team, we have a packet of, it's called 99 coping skills, and we have another packet with 101 coping skills. And it gives you just a myriad of different coping skills that you can use. So introducing them to new coping skills that they can have. In the next section, you will see it's supports and appointments. So these are your formal supports. So if they're receiving services, if they have a therapist, if they have a psychiatrist, if they have a case manager, if they have any upcoming appointments, making sure they keep track with those and keep those appointments. So these are going to be your more informal supports. And then other plans I discuss with the intervention team. So the other plans is where we will add things like our crisis number, the mobile crisis line. We will also add any types of resources that we feel that they need. So let's say if it's parents and they're dealing, with an autistic child, we may, put a resource down, for a support group for caregivers of autistic children and adults. If it's the death of a loved one, we might recommend grief counseling or a grief support group. If it's a teen who is having, struggles, we would put the phone number for the teen hotline, so they could have a peer speak with them, and they can just, vent. And we also have a regular warm line as well, where that will be adults who are on the other end, but children or adults can call the warm line, and then we will also put other resources as applicable to that situation. If someone has a tic disorder and they're not able to, find a solution, we'll look up resources, of different therapies in the area that could help with that. Some of your common therapies with suicide are your cognitive behavioral therapies to help them, kind of reposition their thinking and their behaviors, as well as DBT, dialectical behavioral therapy, kind of a subset. And then, of course, safety planning and any higher level of care with a psychiatrist where they may prescribe, antipsychotic, antidepressant medications and the like. And so overall, it's very important to even if a client is rated as low for being a danger to self or danger to others, having ideations, is still not to be ignored. It's definitely they definitely still need support. You just have your varying levels of support based on your varying levels of severity. But overall, those are, as a mobile crisis team, if we decide that they are a medium or high risk, then we will transport them to a higher level of care. So whether that be a mental health hospital, behavioral health hospital, or we also have local urgent mental health ERs that are open 24/7 as well. I hope you enjoyed the presentation.